everybody, and thank you for joining this evening. My name is Gabrielle Soroika, and I'm with Treace Medical. I appreciate everyone joining us here tonight for this month's Mastery Webinar. For those of you that are new to our webinars, we like to have these be highly interactive. During the webinar, your lines will be muted, so if you have questions at any time during the presentation, please type them into the questions box in your GoToWebinar control panel at the top right of your screen. We'll monitor questions as we go and answer them when appropriate. We'll also have some time at the end for those questions that may not have gotten addressed throughout the presentation. We are fortunate to have two experienced surgeons co-leading tonight's session. I'm pleased to introduce Dr. Bob Sandrock from Fernandina Beach, Florida. He has completed his residency training at West Virginia University and fellowship at OFAC in Columbus, Ohio, going on to have academic appointments at the University of South Carolina, West Virginia University, and OFAC, where he served as the fellowship program director. He currently operates at his newly established practice in Amelia Island and is a clinical associate professor at Duke University. He is joined this evening by Dr. Mark Easley from Durham, North Carolina, who completed residency at Carolinas Medical Center and fellowship training at Union Memorial Hospital in Baltimore. Dr. Easley is the current chief of the Duke Foot and Ankle Division, treasurer of the International Federation of Foot and Ankle Surgeons, and a past president of AOFAS. Both Dr. Easley and Dr. Sandrock actively contribute to Treace product development, clinical research, and medical education training. I'm looking forward to each of them sharing their experiences with you tonight. And with that, I'll turn it over to our faculty for this evening to get us underway.
Thanks, Gabby. This is Bob Sandrock, and good evening to you, Mark.
I'm here.
Yeah, good. You know, tonight's topic is a fun one. We've kind of built this off of a talk that Mark has been giving the last few months at our mastery techniques conferences that we've been having for Treace Medical. And with that, we have been able to come together with a bunch of things that we find pretty much the tips of the trade, tricks of the trade, you might say, in treating bunions. And so it's been a long journey. Mark and I are older guys now. We've had lots of experience, but it seems like every day we continue to learn, don't you think, Mark?
I do. I think we were on a call just this week and you said I was older than dirt.
I think I said we were older than dirt, but maybe I did say, maybe it was slip and I said you were older than dirt. You're right. We're consultants for Treace Medical, which means we're paid hourly for our time. And we also have access to royalties, and you should just have that information available to you. Treace wants to make sure that you have all the information you need to safely deploy their products. So please refer to all the appropriate literature that accompanies the material that you might hear tonight. And our opinions are mine and Mark's, and they're not necessarily representative of everything for Treace. Tonight, we're going to be talking about really the tips of the trade, what we use to try to help improve our bunion algorithms, our bunion care for patients. And with that, we'll do some illustrative cases as the bulk of this talk. But throughout this, we'll have some tips of how we get there both before surgery and after surgery. And we're calling that perioperative optimization and support. Essentially, it's not just about the bunion surgery itself. It's about all the things we do to try to smooth out this pre to post surgical care of a bunion patient in our new evolved world that we live in. And we'll start there with the procedural algorithm and patient selection. And this algorithm, we've been using this graphic for a while now, and it helps you kind of peer into how our thought processes are today in 2024. If you remember back, this journey started in 2014 for us. And with that, I want to get you kind of into the mindset of the 7 guys that have been with us since the very beginning, including Mark and I, that Lapiplasty is really a philosophy. It's not a single surgery, although that is the title of the triplanar first TMT arthrodesis. It's a philosophy of how to treat bunions three-dimensionally, how to get reproducible results from instrumentation, and then how to get to immediate weight bearing safely. And with that, those 3 goals in mind, it's a new philosophy of how to treat bunions that is expanding beyond just the original Lapiplasty surgery, but moving into MTP joint arthritis, moving into metatarsus, and moving into MIS techniques. All these things have the same 3 goals: 3-dimensional correction, reproducible instrumentation, and immediate weight bearing. And Mark, I think this algorithm has really helped us streamline that and give us a philosophy that really, above all things else, gives us a technique to get to the same place post-operative, which is the same protocols for all of these scenarios that map out, if you have anything to say about that.
No, I agree, and this does help me understand, and it gets a little intimidating when you start seeing somebody present a case like the one you see on the bottom line all the way to the right. You say, oh my God, you fused the entire midfoot and forefoot. Well, as long as the principles are followed and the alignment is proper, you can actually do a quad. So if you haven't done it yet, you may have situations where you have metatarsus adductus, a bad hallux valgus, and arthritis of the first MTP joint. And then you put all the principles together, you follow the adductoplasty type principles, you follow the Lapiplasty principles, and then you follow the principles for a proper MTP joint arthrodesis. And I tell you, much to my, it took me a while to embrace this or really get my head around it, but when I do that operation in those patients that need it, that patient functions just like a patient of mine who had an isolated first MTP joint arthrodesis. So I think the principles are great to look at this comprehensively and realize that if you follow it properly, these will really help you really organize your care for patients, even in complex situations, and give your patients the best possible outcome in a very reliable and reproducible way.
And recover the same as all 5 of those, as 7 of those pictures show. And we've not just published on Lapiplasty, we published on doubles recently. So the quads are coming. We're collecting that data now. Everything we do, we try to put some evidence behind it. And really the thing to take home from this slide is that OA is common, TA, metatarsus adductus, is common in your bunion patients. You have to look for it because they trigger decision points. And if you see what's first is the first decision is OA. That means you have to look for OA first. If there's OA of the MTP joint, you should be thinking there's arthritis that is a must to be addressed. And we'll talk about some of that as we go along. So I think this has really helped us out. And those of you who didn't screenshot that, I'm sure you can get that copy of that as well from your reps. We have those little cards to give out. Mark, a lot of people ask us about patient selection. And if you don't know, Mark and I are part of the group that mans the text stream that your reps will send us cases to review, good, bad, and indifferent. And a lot of questions we have come up about patient selection. And so we threw a few bullet points out here. And some of this is really just my opinion and Mark's opinion too. And I personally say neuropathy, even when subtle, it's a contraindication for me. Now maybe that's a harsh line, but the harsh lines are meant to be like stop signs, right? You should stop and think at least. And that's, for me, I kind of draw the line there because this hardware was designed to be safe for early weight bearing. Well, when somebody has neuropathy, I'm not so sure they know how to walk safe even for their own bones, let alone hardware up in there. What do you say, Mark? What do you think about neuropathy?
I think that's a good point. And I love it when the cases come in and there may not be all the history there that we need, but the group, and you in particular, I love it when you focus and say, this just is not standard hallux valgus, or it's not standard arthritis. This looks like neuropathy. And then you make sure that the team follows up with the surgeon who's asking the question. And sure enough, it turns out there's neuropathy. And then you make the point, this is a different animal. So I do really like the fixation that Treace had, and you in particular as one of the founding surgeons and researchers in this, but you want to have a little bit of motion, that flexibility where you get secondary bone healing. So it's unicortical fixation in a biplanar manner that allows for, with early weight bearing, a stable construct, but that little bit of motion that then allows for secondary bone healing. And that's what you want in the majority of cases. But if it's neuropathy, then you start thinking Charcot, and neuroarthropathy is a different animal. So that for me is a contraindication, not necessarily for the principles as far as getting the alignment right, but the fixation needs to be different and the weight bearing status needs to be different.
Yeah, I agree. And you know, large part of neuropathy in the United States is mediated by diabetes, and this is a little bit of a Bob Sandrock soapbox thing here, but you know, pre-diabetes is a real juggernaut in our medical system these days. You know, pre-diabetes is kind of like saying kind of pregnant. It just doesn't make sense. I mean, you know, you either are diabetic or you're not. Now, you may not be full-blown metabolically diabetic requiring medication, but it doesn't mean that the body isn't metabolically in diabetes. So I try to counsel my patients that pre-diabetes to me as a surgeon is diabetes, and I therefore have to know your A1C is less than 7.0. Why do we pick 7.0? Well, it's been proven across many different disciplines in surgery that the threshold of injury to the body starts at 7% of hemoglobin glycosylation. So if you end up with at a 7, then you're prone to retinopathy, nephropathy, neuropathy, and you know, cardiomyopathy. All the things that can get damaged happen at that moment. If you could keep your blood sugars below 7.0, probably neurologic damage isn't happening, which is the key thing for us. And so that's why I picked 7.0. Is it a hard rule? Well, it's a hard rule till it doesn't have to be a hard rule for me. I mean, I guess there's people that do pretty good to get themselves down somewhere around there, but I use it as my threshold before I will think further. Anything to add about diabetics, Mark?
Well, the threshold of 7.0 is important. I'm just a carpenter, right? I just fix things, try to realign them. I am not on the medical side of it. So my hospital doesn't even allow me to do elective surgery if it's above 7.0. So the decision is really taken out of my hands. I have to override the system. You know, maybe in a trauma that needs some urgent care, that would be one time. But for me to do an elective hallux valgus surgery, the hospital just says, we're not going to allow you to do that because it's just not safe for the patient. So it's really taken out of my hands. And that's a pretty strong message to me when you have internists and people that are far more adept at medical management than I am making those decisions, then I certainly listen.
And the same goes with smokers, right? I mean, the risk of complication goes up when you add smoking into the system. Smoking has a lot of toxins and a lot of carbon monoxide poisoning to the cells that we need to have there to heal the tissues. Is it an absolute that a smoker won't heal a wound? Certainly not. But you know, it's one of those things. Like you hope that your airline pilot makes sure all the dials are in the right place on the dashboard, and he's checked the weather, and he's looked for traffic, and he's talking to the air traffic controllers, and everything's right. I mean, you just wouldn't want them to ignore one of those things to take your plane off. And so I advise caution, and it becomes actually more important to me now that I've got smaller incisions. Now that may sound ironic, but remember, smaller incisions they still have to heal. And if we're really manipulating the incision a lot, I think that's where the damage to the incision, to the skin happens. It's not so much the knife as it is the actual pulling and tugging of the tissues to work within a smaller window that actually kills tissue. So I put that caution out there. Maybe you hadn't thought about it. Smoking is not safer in a smaller incision. It actually might be just the opposite. That's my opinion. I don't have a proof of that yet. I don't think anybody's published on that yet, but that's certainly the way I think. Mark, anything about that before we move on?
Well, just aside from the soft tissues, the bone healing, you know, I think that it's been shown over and over again. A lot of it's done in the trauma literature, but it's also for elective surgery. There's a direct correlation. So I think you have to ask that question, and I don't think you need to press on if the patient says, yeah, I'll cut it back some. That's never going to happen. Just why would you put the patient at risk? And then it becomes not just the patient's problem, but your problem, because then you have to deal with it when you do good surgery, but they just don't have the capacity to heal because they have nicotine on board.
Yeah, and so you heard it here, folks. If you're listening from anywhere around the country, Mark is sitting in the area where these three things happen the most, right? He's in the South, where everybody's got diabetes. He's in the South, where everybody's got complications of diabetes. He's in North Carolina, where tobacco was ruled, and so it still has a high smoking population. So Duke University says, watch your A1Cs and try not to smoke. It's just good practice to help you push these patients to the right, level of recovery. And so I think that's something to always keep in mind. One of the things I've done in my practice is I've moved on to private practice, mostly because I was in university practice forever. And the thing about university practice is it turned into a big business. And for me, I got lost in the big business. I got lost in the protocol of business, medical business. And I couldn't deliver the personalized care to my patients that I wanted. So for me, I wanted to move to private practice to do it my last phase of my career the way I wanted to do it. With that, it let me really open up how to treat my patients, how to educate my patients my way. And Mark says he's just a carpenter. We all know that's not true. He's an excellent doctor. And I like to try to pretend like I know a little bit from medical school and try to remember my biochemistry, anatomy, and physiology. So when I approach my patients, I'm always teaching them that there's three parts of my solution to your problem. It doesn't matter if you came in with arthritis or a bunion, but I'm going to replenish the body. I'm going to restore those physiologic things that make you healthy, which includes vitamin control. I'm going to do the rebuild. That's my part. That's the surgery or PRP or whatever tool I'm going to use to replenish the body. Rebuild the body, rebuild what it is. And then the restore is the last part, where I'm going to use all the aids we need afterwards, such as physical therapy, any kind of compression sleeves or proper orthotics and such, to get us that maximal control as early as possible so that I can really push them along. For me, this has really been something that patients grab. And for those of you looking for a way to get your patients invested in this in their own surgery, you give them these three things you want to attack with. They use those tools and they feel like they're actually contributing to the part of the recovery, which is a hard thing to do these days. A lot of people want passive, immediate satisfaction. So for me, this has worked really well as a methodology. And if anybody ever wants to talk about it, you'll be easily can get my email from your reps, and we'll happily go over with you how I do my methodology. But this goes with what we were just talking about. Look at the whole patient and try to give them an opportunity. So with that, preoperatively, I go through a lot of information about the patient for nutritional recommendations. These are simple orthopedic level nutritional things, right? Good multivitamins. Extra vitamin C and extra vitamin D are very important around surgical indications, right? Vitamin C, we all know we take it for colds and for our immune system, but it's antioxidant, so it helps get out debris, it helps remove free radicals, and it also protects the nerve endings quite a bit when they've been damaged. And how do nerve endings get damaged? From swelling, from tourniquets, from all these things that we're doing in surgery. Vitamin D is the absolute most important thing I've learned physiologically in the last 10 years, is how important it is to bone health and body health and repairing from injury. I learned it from Duke. I learned it from Dr. Nunley teaching me about this 10 years ago, about how important it is. And now you can't have any kind of surgery, whether it's cardiothoracic or other, without somebody asking about your vitamin D. I was really surprised when I moved to Florida that people are still vitamin D deficient down here in the Sunshine State. There's probably something weird going on with our diet, that we're not absorbing vitamin D like we once did. And so really high quality vitamin D at a good doses is really important. You might hear that normal vitamin D is 40 deciliters, but I will tell you that for me surgically, I try to have people above 50. Now I don't get tests on everybody, but I do try to absolutely have an understanding of the patient. They're going to be trying to be super normal on vitamin D, and that's been my recommendation. Protein. I tell people you're using up all your vitamin D to heal, and you're using up all your protein to heal. So you need to tank those systems up as much as possible. Now, personally, I like Premier Protein. It's cheap and it's available everywhere, like at Walmart, 30 grams in a little carton, and you try to get 2 of those a day if it's appropriate with their medical doctor, that they don't have kidney disease and have a problem with protein. And with that, I feel like that's your good supplements. That's your baseline. And the right-hand column over here is what to do to try to get people to have a balanced diet. And, it's essentially, if you reduce wasted calories, if you reduce carbohydrates, you will reduce inflammation. So that's what all these sugars and things do, is that they create carbohydrate waste, which creates inflammation and rises that. Well, we're fighting inflammation. We only want the dialed in amount of inflammation. We don't want over inflammation in our healing. So then, of course, we want the bodybuilders, all the good nutrients that come in vegetables, as well as the meats with the proteins. Anything to add here, Mark, that you do in addition to these kind of general recommendations?
No, these are good, but I do want to emphasize that, yes, we want to get to the complex cases and talk through the cases. I'm really happy that you added this, because this is something we overlook, and you can do the best surgery you ever have done, and you can get perfect bone apposition, and you can follow all the principles and follow all the post-operative protocol the right way and still have a poor outcome because you don't pay attention to this. And it just, you hate to blame the patient, but it's the patient's fault because their nutrition isn't what they need it to be. And it is really on you. You have the opportunity to change that too. So, if nothing else, get your camera and take a picture of this and think about these things as you bring your patients to surgery. So they need to understand that they have some responsibility as well to make sure they're optimized to have the best possible outcome. It's not just your surgery, but it's how they respond to it as well.
Really quick,
Yes.
Dr. Easley and Dr. Sandrock, we have a question about what pre-op labs do you order routinely?
Yeah, go ahead, Bob.
Yeah, so I order, most of mine is driven by the anesthesiology requirement. We work with our anesthesiologists, and I try to get some information from the labs they're going to need. So for me, it's a generally just a chemistry and a CBC is all it's required, unless I have a history of diabetes, then I'm going to get an A1C. Unless I have a history of nutritional deficits in the past, malnutrition or vitamin D deficiency in the past, then I might check those, and I might check albumin in addition. So if I don't have those, I don't trigger them. But what I do look at in the CBC, the differential, is I look for the total lymphocyte count. The total lymphocyte count is a really good reflection of somebody's overall nutritional status. If they have a less than 1,500 total lymphocyte count, they're essentially malnourished, and that would equate to a less than 3.0 deciliters of your albumin. So I would say that's a good sheet, a way of getting something your probably your anesthesiologist needs anyway, and you can look at their nutritional status there. But if they have a nutritional deficit problem diagnosed in the past, if they have a diabetes problem, then we're going to check those specific labs. Of course, there gets into the specifics, of course, anticoagulations and other things like that. But as a routine, it's not that much for me. It's more of a history taking and talking to the patient. So,
do you just assume that everybody has low vitamin D and you supplement them?
Yes,
You actually order a vitamin
well,
D?
I'll tell you what I assume. I assume nobody is super normal, and a handful of people are super normal. I have had people who are taking supplementation, and I put them on additional supplementation, and then they're doing fine. They're not having side effects of any kind, but they go in for a routine test, and their primary doctor says, "Oh, why are you on vitamin this